Okay, I want to talk about Lyme, or better yet, Post-Lyme Syndrome. I'm not going to go over treatment of acute Lyme disease with antibiotics. I'm not going to go over antibiotic protocols for tick-borne diseases. I'm going to go over what I do. And what I do is very little with antibiotics and a heck of a lot with inflammatory markers. Specifically, I want to talk about the inflammatory elements that contribute to post-Lyme syndrome. And by the very fact that you've been through 8 hours of talk so far, you should pretty much be predicting that the same markers that I use for mold and other biotoxin illnesses, I'm going to use for Lyme. And that's exactly the case. And specifically, I want to kind of hammer home the point of deficiency of T regulatory cells, because that's better described in Lyme than other illnesses, although it is now described in coagulase negative staph and multiple sclerosis, and I think we're going to see a flood of papers coming up. This is brand new in my reading of the immunology literature, and I look forward to really defining what happens with pathogenic T cells, or not me defining, someone else defining with laboratory data what actually is going on. I think you've seen my attitude is pretty negative about assumptions. My attitude is pretty negative about guesses. I believe in data, and I want you to collect data. And we've already talked about inflammatory pathways and TGF-beta1 and my friends C4A and MASP2. So some of that will be review. I did mention that there are two sides to this argument. Some groups, I cynically say, is antibiotics for never. There are some people that say they don't have Lyme disease here, there, and everywhere. Some people may argue with what the CDC reports as cases of Lyme disease, but Lyme has been reported from every single state in the union, including Hawaii. So you might want to take a look to see what the CDC has. There are other people that disagree with me, and they use antibiotics for very long periods of time, and I'm not about to argue with them. I'm just going to say that I don't agree. And specifically, people that are reasonable human beings are allowed to disagree, and we don't have to be right or wrong. But I don't think either side of antibiotics forever or antibiotics for never can afford to overlook the inflammatory elements that are present in patients. And if they would look carefully, they would see these things are obviously present. Now, I love my truck, and I won't bore you with my Uncle Versi Ledbetter. I can tell you some other stories. Man, I love Jerry Clower. But anyway, the real issue is that you hear things that are wrong, in my mind, about Lyme. 90% of Lyme patients have erythema migrans rash. Well, that's silly. You know, that has never been reported in literature until very recently, and I don't think we can ignore what's been published before. 95% of patients only need short-term antibiotics. Well, that was never the case in prior literature, and only recently do we hear some of the same people that published 20% post-Lyme syndrome now saying 5%. Come on, guys, let's get off the polemics and get back to taking care of patients. And then we have some people that maintain every Lyme patient has got tick-borne disease, and if you've got a tick-borne disease, you therefore have Lyme as well. Well, that also is not true. All I can tell you is that this is a situation where you really must be careful in data collection. Look carefully at your laboratories. If they are a lab, quite frankly, that expects to be paid with cash, all I can say is I insist on split samples, and I insist that split samples be correlative before I use those labs. That doesn't mean that non-cash labs are always reliable. We've talked about lab errors. We know full well that the lab-to-lab variation in test results is a problem. Steve Dumler at Hopkins has published some very nice work showing that there are many abnormalities found in Lyme from the inflammatory areas, and we should pay attention more to what he said than sometimes what people do. My friends TGF-beta1, C3A, and C4A really do come forward here through these talks. I've talked to you about a number of these different pathways. You need to know that attach to a CD4 CD25 cell is a nuclear replication factor called FOXP3. FOXP3 is made from FOXP0. FOXP0 is acted on by a kinase to stick a phosphate group to make FOXP3. If you do not make FOXP3, this pathway of injury from CD4, CD25s to pathogenic T cells apparently does not occur. And the question then comes up, if we look at the role of low CD4, CD25 cells, and we fix that, including using elements like VIP that drive those up, and we block FOXP0 to FOXP3, will we have an additional mechanism to block the cellular basis of inflammation? And this is a very attractive idea to me because we have kinase inhibitors that are available that do exactly that. That would be another approach to an IRB with a very careful study, and we may do that in the future. You need to know that the mechanism that converts FOXP0 to FOXP3 comes from the phosphatidylinositol 1,3 kinase pathway that's linked to AKT. More gobbledygook for you to put in your acronym dictionary, but you need to know that these pathways are identified and they are a hot item in research. Perhaps next year we can give you some information about P13K in its role with AKT as an additional pathway of injury that people with these inflammatory processes suffer from. We've talked in some detail about antigen processing, antigen presentation. We've talked about dendritic cells, or professional antigen presenting cells. I'm not going to go over that same activity here. I will just tell you that the passage of an immune signal from a dendritic cell to a naive T cell can be blocked by cytotoxic lymphocyte factor 4. And how that all works is prolonging and preventing the attachment of the naive T cell to its T cell receptor. Is immunology complicated? Yes. Do I think I have all the answers? No way. Do I have things down there right? Yeah, I think so. Do I have things that are wrong? I think so too. This is new, and I reserve the right to change what I say based on more opinion. But we do know a lot of things that work in post-Lyme syndrome. And there's a lot of things that don't work. So I'm going to focus as best I can on what does work. We really need to make sure that your Lyme patient is a Lyme patient. I use C3A and C4A. We've talked about that. There's a question earlier from John, and this question is, if you have defective antigen presentation, is there going to be reliance that is merited on an antibody test? And it's a reasonable question to ask. We know that where people fail in management of post-Lyme syndrome is that antibiotics will never fix MSH and VIP deficiency. Antibiotics will not fix T regulatory cell physiology in those with HLA susceptibility to post-Lyme syndrome. We also have got to deal with an assumption, there's that word again, that once Lyme disease, always Lyme disease. Lyme, when it's there, will change the host such that as time goes by, HLA susceptibility to other illnesses will be expressed, and if they had Lyme last year and they was treated successfully, a year later they get sick again, do not assume that this is a cyst phase. Do not assume that this is a co-infection that was latent. Be looking again as if this were a new illness. It probably will be. The other thing I need to ponder is that I have little spots on my lung, on my chest x-ray, and I test positive to a skin test for mycobacteria battii. And I have these atypical mycobacteria that are alive, and they're in me. Do I have atypical mycobacteria pneumonia because I have these granulomata in my chest? No, I don't. And if we see a spirochete inside of a fibroblast, does that mean that that person is affected with Lyme? I actually don't think so. Could there be sequestration of living Lyme organisms within tissue, like the granulomata. I think that may be the truth. But the real issue is that I don't have the capability, as we sit here today, of looking at synovial biopsies and staining